And what I would like to show you in the next 20 minutes, it's something that we are working for a long time and showing the results about what we have now and even about the app that we launched recently through the AGL. We know that when we start to discuss this topic, it's important for us to realize why do we really need a new classification for endometriosis. We know that endometriosis is a very complex disease that where we have probably different diseases with the same name, considering the peritoneal endometriosis, the ovarian endometriosis, and the deep infiltrating endometriosis that may compromise different organs. And when we talk about this complex problem, we need to realize that there are many classifications that were done in the last decades, including the classifications from Acosta in 1973 and other classifications, but very few of them consider deep endometriosis and consider the sites of the disease, right, to show precisely what we are talking about. So this is why a few years ago we published this study showing that possibly we can improve the last classifications, including the last AGL score system that was done in the last version in '97. So when we talk about this, which are the criteria for a good endometriosis classification system? It must be something that is easy to perform, that have a high reproducibility, that may be helpful across a wide range of endometriosis, as I mentioned before, that must be helpful to predict the prognosis of the disease, because this is very important for us even to discuss the therapeutic alternatives, therapeutic options with the patients, and with a good correlation with the surgical difficulty. So if you think about one of the systems that are most used by now, the American Society for Reproductive Medicine classification for endometriosis that was last updated in '96, right? We know that possibly in situations like this, with a patient with 32 years old, with severe dysmenorrhea, very strong pelvic pain, non-cyclic pelvic pain, and infertility. And then if we try to use this diagnostic laparoscopy that you can see here, that we did many years ago, to try to stage the disease that is causing so many symptoms, we can see that possibly this patient had 1 to 3 centimeter deep endometriosis, considering the stage 1 disease, because it was 4 points. But does it reflect precisely the pain of the patient? When we open that peritoneum and try to see what we have behind the peritoneum, we can find a deep lesion compromising the bowel that was not included in this classification. So this is why probably when we talk about the staging systems that we have nowadays, right, we can, of course, we can leave behind important characteristics like this disease compromising the bowel that should be included in a new classification. And even for systems that we have that was more recently described, right, like the MSERM score, systems like this, they are not as user-friendly as what we are going to show you in terms of allowing not only general gynecologists from all over the world, but also non-gynecologists like radiologists to stage properly the disease. So this is how we treated this lesion compromising the bowel. It was a lesion with less than 3 centimeters. So it was possible to do a disc resection of that lesion, of the bowel, remove that disease, remove the retrocervical lesion, allowing the patient to improve of the symptoms. So this is why a few years ago we started working on this through the AAGL, American Association for Gynecological Laparoscopy, that allowed us to perform a multicentric study towards a new endometriosis classification as an anatomy-based surgical complexity score that is very relevant for this purpose. So some colleagues from the US, from Spain, and from other countries, and I, and my team here, including me, Marina, and John Silfi, we decided to work on this new score system, asking 31 endometriosis experts to provide scores from 0 to 10 regarding the impact of various disease sites on surgical complexity. So what we did was to circulate to these colleagues from all over the world many years ago questions like, which score would you give according to the importance of the peritoneal endometriosis from 0 to 10, considering that 0, of course, is less important than 10, right? Ovarian endometriosis with different sites, deep endometriosis comprising important regions like retrocervical endometriosis, endometriosis comprising the vagina, the bladder, including the infiltrated muscularis, rectovaginal septum, rectosigmoid with different sizes, endometriosis comprising the ureter, the appendix, the small bowel and cecum, cul-de-sac obliteration, if it's partial or complete, and the tubal conditions, including the mild serosa injury, moderate immobility, severe immobility, or complete obstruction. So when we circulate this spreadsheet to all of these colleagues, they responded us with scores showing that, for example, that from 0 to 10, some of the colleagues gave, let's see here, 1 point for peritoneal disease, 3 points for peritoneal disease with more than 3 centimeters, and with characteristics like this, and we just excluded one of the data considered outliers according to these characteristics. So when we received this information, we made an standardization of the mean scores from 0 to 10. And in this standardization, we checked for the consistency of the data using this strategy that is a statistical strategy that is called Cronbach alpha test. And we know that when it's between 0.7 and 0.9, the consistency is very good. So according to these mean scores, we approached these numbers here that provided us some scores. For example, superficial disease with less than 3 centimeters, 2 points, more than 3 centimeters, 4 points, and for example, left ureter with ureter 9 points, and so on. The disease compromising the bladder, the bowel, so with very important information that were considered for us to show the importance of the disease. So with this data, what we did was to perform a prospective study involving a multidisciplinary, multicentric prospective study, including initially 1,500 patients submitted to laparoscopy. We excluded initially 343 cases, some of them with incomplete data, others without endometriosis, and the final number was 1,200 cases where we evaluated the surgical complexity, the scores from AGL and ASRM, the clinical data, and the transaxional ultrasound. And considering the surgical complexity, we divided these cases in 4 levels of surgical complexity. Level A, excision or dissection of superficial implants, or simple thin avascular adhesiolysis. Level B, stripping of the ovarian endometriomas, appendectomy, deep endometriosis not involving the bowel, vagina, ureter or bladder not requiring suture, and dense adhesions not involving the bowel or the ureter. Level C, dense adhesions involving the bowel or the ureter, bladder surgery requiring suture or ureterolysis, bowel surgery without resection, and level D, bowel resection of ureteral implantations or anastomosis. So considering this, the first step for us to do it is to define the cutoffs for scores using log curves that accordingly distinguish among these complexity levels. As you can see here, and 1, 2, and 3 versus 4, you can see here that we defined this 4-stage system, including the stage 1 with less than 8 points, stage 2 between 8 and 15 points, 3 between 15 and 20 points, and stage 4 more than 20 points. And then the last step of this study was to evaluate some symptoms like pain and infertility, considering the visual analogic scale and considering the infertility before surgery that was documented. So when we see this, the first results of this study was that when we compare the AGL and the ASRM system, we realized that the surgery complexity is more captured accurately by the AGL system than the ASRM with a better reproducibility, as you can see here. So the kappa for AGL classification was 0.6 and the kappa was 0.49 for the ASRM. And another important information is that in only 60% of the cases, there was an agreement between both stages, meaning that both classifications are truly different in terms of the comparison between both of them. When we check the symptoms, one of the conclusions that we had was that the AGL system discriminates symptoms no worse than the SRM classification, what is a very important information to be considered. And in conclusion, we showed that the SRM 2021 endometriosis classification allows for identifying objective intraoperative findings that reliably discriminate surgical complexity levels better than the SRM staging system. What is very relevant, and more than this, right, is that we can check using this system precisely the sites of the disease, right, and even to discuss with the patient to reduce the complication rates, right, what is so important for this kind of disease. And also that the AGL severity stages correlates comparably with pain and infertility symptoms with the SRM stage, what is very relevant for us to check. And then the next step was that we launched recently an endometriosis classification app that you can find, and I stimulate all of you to go to your application, to your app store from the phone that you can use, and download, right, this new system that you will see there that when you open the app, you can see this paper there, right? You can even read the paper there that was published recently in the JMIG in November of 2021. And then when you click here to stage a patient, you are going to see, right, you are going to check where are the disease, for example, if the patient has peritoneal superficial disease, less than 3, complete moderate immobility of the fallopian tube, the right, the left, and you are going to see there all sites of the disease that you can check where is the disease, and in the end, you're going to find the stage, right, the number of points, the stage of the disease according to these points, that you can create a PDF, and in this PDF you can fill here the name of the surgeon, the hospital, some important notes like other, how was the motivation, even if the patient has other problems like adenomyosis or other information that you can include, creating the PDF, and this PDF can be sent right to your email, or you can even use this PDF to add to the reports of the patient. So I truly recommend you to download this app and to start using this as soon as you can, to see, of course, how helpful is this for your patients and for yourself. Thank you so much. Again, it's a privilege to be here, and I'm here for